Hey guys, so welcome to the first review for the third exam for Psych 237. So most of you probably know me by now. I'm Claire, and I'm one of the Thomason team members.
Hey guys, so welcome to the first review for...
Okay. Sorry, I have to have the, hi. So as usual, we have quite a few questions to get through, and only an hour, but we'll have time to stop if anything needs clarifying. So I figured out how the live chat works this time, so I can see live questions now, which is why you heard me talking earlier, because I have the stream pulled up next to me. So I'll try to check that every few minutes. So until we get through all the questions that were posted on my courses, I'll only be answering clarification questions and the answers that I'm giving. And then if we have time at the end, I can answer just general questions, if that makes sense. So keep in mind that there's another review session happening tomorrow night, and Aislin's hosting that one. I think it's from 7:30 to 8:30. So if I don't answer your question tonight, or if the way I'm explaining a concept doesn't make sense to you, you can watch that one, or as always, email our TA account. Okay. So last time I kind of rearranged the questions to be in chronological order. This time I'm just going in the order that they were posted. But for some of the questions were very conceptually similar. So I grouped them together. So if I don't come to your question right away, it's probably because someone else asked a similar question. Okay, so the first question was schizoaffective disorder. To diagnose, do you have to have schizophrenia or mood symptoms at the same time, or does it not matter as long as you're having one without the other, but have had the other at some point? So this is definitely a tricky diagnosis. The mood disorder symptoms should be present for the majority of the illness. However, you also want to see delusions or hallucinations in the absence of a mood episode at some point over the lifetime duration of the illness. So basically, it needs to be clear that they're experiencing, for example, depression with psychotic features. So that's why you need to see the delusions or hallucinations without the mood disorder symptoms. But still, those mood disorder symptoms should be present for the majority of the illness. So I know that's a little bit tricky, so you can let me know in the chat if you want me to repeat that. But for now, I'll go on to the next question. So what does good versus bad prognosis mean? Asked bad and good prognostic indicators for schizophrenia. So having a good prognosis means that someone with a disorder has a more favorable outcome. So for example, maybe they'll have less severe symptoms, or they'll experience symptoms less consistently. So someone with schizophrenia might experience hallucinations or delusions, but won't consistently be in a psychotic state. So just keep in mind that good prognosis doesn't necessarily mean being completely symptom-free. It's just being at a generally higher level of functioning. Okay, can you explain sensitivity and specificity? Do you want a biomarker to be both sensitive and specific, and why? So sensitive means that most people with the disorder have the symptom. Specific means that most people with other disorders or people who are healthy don't have the symptom. So yes, you would definitely want your biomarker to be both of these, because that just by definition makes it a good biomarker. So you want your biomarker to be seen in most people with the disorder, meaning that it's sensitive, and you also want it to not be seen in other disorders, specific. So you want to be able to identify people with an illness using this marker. So that's why you want it to be both, so that you're catching the right people. What's the difference between a disease marker and a sensitivity marker? So a disease marker is something that occurs in nearly all people with the diagnosis. Sensitivity, kind of like I was saying, is more of a characteristic of a good marker. So you want your marker to be something that's seen in most people with the disorder, meaning that you want your marker to be sensitive. Okay, the professor made a comment about environment in regard to the Fisher study graph. Why do we overestimate heritability of these phenomena based on type of twins? And then someone also asked about, do monochorionic twins have the highest heritability estimates? So I have the diagram here. Okay, so here's the Fisher study diagram. So what we're seeing here is evidence that schizophrenia has genetic influence. So this study looked at monozygotic twin pairs discordant for schizophrenia. So that just means that one twin has schizophrenia, the other twin as well. So the rates for developing schizophrenia were much, much higher in the Will twins' offspring compared to the general population, which is what suggests the genetic influence. But twin studies usually assume that the environment from monozygotic twins is no more similar than the environment for dizygotic twins. So by assuming that the environment is not more similar, we're overestimating heritability. And why is that? It's because 2/3 of monozygotic twins share a placenta in utero, whereas dizygotic twins never share a placenta. So basically, monozygotic twins have this extra component where their environment is more similar than that of dizygotic twins. Okay. For schizophrenia, is it social selection or causation that is currently believed to be the risk factor? And someone else asked about the risk factors slide in the schizophrenia lecture. On the slide, it says high rates in immigrants support social causation, but in the lecture, she said it's selection. Which one is correct? So the risk factor for schizophrenia is the fact that, well, is being in a lower SES or social status environment. So social selection and social causation are two theories as to how it comes to be that people with schizophrenia tend to have lower socioeconomic status. So in the social theory, basically it's believed that factors in society exert forces on individuals, and that is what causes schizophrenia. So the way in which our society is set up is what's causing these increased rates of schizophrenia in lower SES populations. On the other hand, social selection, people with schizophrenia or who are at risk have lower functioning compared to the general population. And this is what makes them drift downwards into poverty. So another name for this theory is downward drift theory. So the way we tested this was by looking at families of people with schizophrenia. So in a social selection theory, you would expect to see differences in the family and also in the afflicted individual, but it appears that there aren't necessarily differences. So people with schizophrenia don't necessarily come from lower socioeconomic families. So the fact that people with schizophrenia aren't all from lower SES families lends itself to the social selection or the downward drift theory. But there's also evidence for the social causation theory. So this evidence comes from the study discussed in class, which looked at immigrants to the UK and the Netherlands and from the Caribbean and Africa. Oh, sorry, immigrants to the UK and the Netherlands from the Caribbean and Africa. So you see higher rates of schizophrenia in these recent immigrants, as well as their children, who actually seem to have even higher rates. So why does this support the social causation theory? Well, if you look at the countries of origin for these immigrants, have higher rates of schizophrenia in their respective general populations. So it seems like it has something to do with the immigration process itself, so possibly related to stressors that result just from being an immigrant. Okay, so we had some questions in the chat, so I'll read the questions in the chat out loud. I don't know if people will be able to see them later. So someone asked, will the answers to the posts on my courses be answered there? Or is there only a possibility for clarification on the questions asked through these live videos? I won't also be posting them on my courses, so the answers to all the questions will be in my video, and then questions that people are posting now or later tonight and tomorrow will be covered in Aislin's review session. And then someone else asked, we're discussing the monozygotic occurrence of sharing placenta and how this may be an environmental factor in the context of schizophrenia. But is this something we should remember for all other illnesses discussed in the course? So we've only talked about this in the context of schizophrenia. I think it's just general when looking at twin studies. But definitely say keep it in mind in the context that we covered it in, so in the context of schizophrenia. So you can let me know if you have any more questions. But for now, I'll go to the next, my courses question. So what is the role of dopamine in schizophrenia? And then someone else also asked the relationship of schizophrenia and working memory. Someone wanted me to go over the dopamine hypothesis and why it's important. And also, I'll be covering the Holtzman study that we covered. So I'll also be answering the results of, I'll also be going over the results of that study. So dopamine has been implicated in a variety of structures in the brain. So we see excess dopamine transmission in the striatum and reduced dopamine transmission in the frontal lobes in people with schizophrenia and that. So the striatum is important for the motor system and the reward system. And you can see both abnormal movements, specifically in the oral facial area, and problems responding to rewarding stimuli. And there's also the idea of aberrant salience, which is the idea that people with schizophrenia, because they have this increased dopamine, might attend more to irrelevant stimuli in their environment, which might make it harder for them to make sense of the world around them. So the dorsolateral prefrontal cortex, on the other hand, seems to be an area with less dopamine transmission. So normally this is an area heavily regulated by dopamine, and it's also critical for working memory. And there's evidence of cognitive deficits in schizophrenia, and that area appears to be related. So to go over the working memory deficits, I'll just pull up the slide. Okay. So an example of the working memory deficit seen in schizophrenia is the Park and Holtzman study that we talked about in class. So this study had 3 groups, healthy people with schizophrenia and people with bipolar. So basically in this study, subjects, I believe, had to find a target behind a screen, and then once they found where the target was, then they had to perform a distractor task, and then they had to remember where the target was that they had previously found after the distraction task. So deficits in working memory were exclusive to the group of people with schizophrenia. So the group with bipolar and the healthy control group didn't show this problem. Okay. So kind of in the similar vein, why does the use of L-DOPA support the dopamine hypothesis? So basically, it's just the effects that we've observed in people with Parkinson's that are taking L-DOPA. So obviously, L-DOPA is a drug given to people with Parkinson's, and one of the potential side effects is hallucinations, and it's believed to be because it's boosting dopamine activity. And obviously, sometimes we see hallucinations in people with schizophrenia. So what does a single hit hypothesis mean? So I don't believe we've talked about, I don't think there is really a disorder that has, that would be supported by a single hit hypothesis, but this is the multiple hit hypothesis for the development of schizophrenia. So you can see that there are multiple factors at play that lead to the eventual development of psychosis. So a single hit hypothesis would mean that one factor leads to the development of disorder. But as with anything in psychology, it's rarely the case that one thing is leading to the observed effects. Okay. Are all or some catatonic behaviors considered positive and or negative symptoms? The book says they're all positive, but in class she said they're negative symptoms. So this is actually a typo in the textbook. I checked with Dr. Weinberg, and it seems an error. So keep that in mind while you're studying. Catatonic behaviors are negative symptoms, they're not positive symptoms, even though it says that in the book. Okay, so just to be sure, was ASD considered to be an umbrella spectrum in DSM-4 or DSM-5? So the umbrella sort of conceptualization was something that was seen in DSM-4. So it was called the autism spectrum then, but it wasn't really a spectrum per se. So instead, autism spectrum disorders was the title of a larger category that encompassed disorders like autistic disorder, Asperger's, and PDD, NOS, etc. Okay, so on slide 28, and this is a lecture, it says that good premorbid adjustment, like having friends, is an indicator for good outcome. However, on the subsequent slide, it says that patients with better premorbid functioning are more at risk for committing suicide. So is this the case? In this case, better premorbid functioning is a poor prognostic indicator. Is this correct? Okay, so people with good premorbid functioning in general tend to have better outcomes compared to people with poor premorbid functioning. So maybe they're less likely to be continued psychotic, for example. It also appears that people with good premorbid functioning are more at risk for suicide and suicidal ideation. So in that sense, it's a poor prognostic indicator for suicidality, but not necessarily the course of the whole disorder. Okay. In the first schizophrenia lecture, disorganized behavior is listed, excuse me, as one of the cardinal or necessary symptoms for a diagnosis of schizophrenia. However, in the DSM-5 and in the textbook, only disorganized speech, not behavior, which is listed later on, is listed. So if a person were to present with, for example, delusions in disorganized behavior only, would they meet criteria for a diagnosis, assuming they met all other requirements like duration and history? Okay, so I'm going to kind of split this into two parts. So in criteria it's on slide 16, it should only be disorganized speech and not disorganized speech and behavior. But to go over the example that you presented, if a person presented with delusions and disorganized behavior, assuming they met all other requirements, they would meet criteria for schizophrenia. Remember that from criterion A, a person must meet at least 2 symptoms, and one of those 2 symptoms has to be either delusions, hallucinations, or disorganized speech. So if a person had delusions as well as disorganized behavior, along with criteria B through F fulfilled, then yeah, they would certainly meet diagnostic criteria. Okay. I don't really understand why manic and depressive symptoms are good features. Will you explain? And this is in the context of prognosis for schizophrenia. So good prognostic indicators aren't necessarily quote unquote good things in themselves. They're just correlated with better outcomes. So a good prognostic indicator just means something that is associated with better outcomes. So people that have schizophrenia and have manic and depressive symptoms appear to, in general, as a whole, have better outcomes than people without. But we don't really know why that is, just that the two are associated. Okay, so someone asked, so it's only disorganized speech that's necessary, not disorganized behavior. Right, so I believe, I'm not quite sure what page it is in your textbook, but it does list the DSM criteria. So there are 3 hallmark symptoms, and you need to have met at least one of them to meet criteria. So the 3 hallmark symptoms are delusions, hallucinations, or disorganized speech. So I was just clarifying on one of the slides in the lecture, it said that disorganized speech and behavior was one of the required criteria, but it should just be disorganized speech. So disorganized behavior is still there. It's just not one of the 3 symptoms that you would need to have at least one of. Does that make more sense? Okay, I'll go to the next question, and then you can let me know in the comments or in the chat box if you want me to go over it again. Okay, so would you mind going over the prospective study on brain hyperexpansion that was covered in lecture? So we covered the Hazlett and colleagues study in class, which was a prospective study of high risk versus low risk infants. And the way they identified high risk versus low risk was whether or not that child had an older sibling who was diagnosed as being on the autism spectrum. So they found that the high-risk infants showed this hyperexpansion. So compared to the low-risk infants, their cortices were getting bigger between 6 and 12 months. So not all infants in the high-risk group went on to develop autism, obviously. But of the 15 who did, when the researchers went back and looked at the data, they found that you could predict who would later be diagnosed with autism based on the observed hyperexpansion. Okay. How are antipsychotics dopamine agonists and not antagonists? I think that antipsychotics would be considered dopamine antagonists because they block D2 receptors, and because of that, dopamine has less of an effect. But if whoever posted that question is watching now, if they could comment and let me know if they got it from somewhere in the slides or in the textbook, I'd be happy to look into it more, just to clarify. But I believe that antipsychotics would be considered dopamine antagonists. Okay, what is the heritability of schizophrenia versus bipolar disorder? In lecture, we said that the heritability of schizophrenia amongst dizygotic twins is 6%, which is lower than the heritability rate for bipolar. So you might be able to find exact number in your mood disorder slides, but I would say just know that the heritability of schizophrenia among dizygotic twins is lower than the heritability of bipolar. Okay. Can you please clarify the differences between the 3 levels of severity more clearly and give an example of each? So this is in the context of ASD, and I'll just pull up diagrams. Okay. So the levels of severity exist for both social communication and restricted repetitive behaviors. So I'm going to go through both, and then I'll give an example for each level within those two categories. So we'll start with the levels of severity for social communication. So level 1 is requiring support. So for example, someone at this level might be able to speak in full sentences, but still would have trouble with the reciprocal back and forth that characterizes conversation, maybe unless someone reminded them to take turns. Level 2 is requiring substantial support. So someone at this level might restrict the conversation topics to a very narrow interest of theirs, like Star Wars, for example. So their sentences additionally might also be less complex compared to someone at level 1. And then level 3, requiring very substantial support. So someone at this level might have very little speech and would rarely approach others unless it was to meet their own needs. So next, restricted and repetitive behaviors and interests. So again, level 1. So someone at this level might have problems in planning and organization. They might have difficulty switching from one activity to another, and their inflexibility causes them problems in at least one context. So level 2, inflexibility of behavior is severe enough to be noticed by others, and functioning in multiple contexts is affected. And changing activities or focus might cause distress. And then finally, level 3, someone at level 3 with extreme difficulty dealing with change in their environment. All areas of their life would be impacted by their inflexibility, and changing activities would cause great distress. So for anyone who's looking for further elaboration than that, there's a very helpful box on page 379 of your textbook that goes into a bit more detail of the specific level definitions, and that's also where I got these examples from, so that might be helpful for studying. Okay. So what does it mean when the course of an illness is heterogeneous? So a heterogeneous course is something that we see in schizophrenia. So in class, we discussed the work of Manfred Bleuler, who followed just over 200 patients over the course of 2 decades. So his goal was to see the outcomes of these patients. So he found that about a quarter of them were continually psychotic. Half had symptoms, but they weren't continually psychotic. And the last quarter appeared to improve over time. So obviously these patients had a wide variety of outcomes. So not only is the disorder itself very heterogeneous, meaning that it can present in a variety of ways, the course of the disorder is often also very different on a per patient basis. So some may be continually psychotic, others may see marked symptom improvement. Okay. I don't understand the sentence, just because something is a biomarker does not mean it is a vulnerability marker or that it plays a mechanistic role. Isn't the whole point of a biomarker of a disease to signify a correlation with the illness? So I'll give an example for this, and you can let me know if it's still not clear. So if a structural characteristic X, and let's say you find that in most people with disorder Y. So obviously this is just an example, it's not real disorder. So you can't really say if X caused Y, if the characteristic caused the development of the disorder. So you can't say that it's a vulnerability marker. And why can't you say that? Well, you don't know if X is a consequence of the disease, so maybe disorder Y results in some altered connectivity in the brain that leads to these structural differences that you're seeing. Or maybe it's because of treatment, so maybe someone's on is causing these changes that you're seeing. So there's no way to know just from examining people who already have the disorder. And it's the same reason why you can't say it plays a mechanistic role, because you can't be sure if it's a scar of the, just because it's present in all people with the illness, you don't know if it necessarily predates the onset of the illness. Okay. So that is your IQ, your cognitive skills, social skills, emotional expressions, etc. All neurotypical for your entire life. It starts to degrade, and then you get an onset of the active phase. In other words, are you perfectly neurotypical, then lose that in the prodromal phase and then develop hallucinations, etc.? Or do you have issues with IQ and cognition your whole life, and they worsen as you age and worsen with stressors, which then leads you into a prodromal stage? So the onset of schizophrenia can either be abrupt or gradual, but typically you see symptoms start to emerge so in both early onset and adult onset schizophrenia, you would typically see early speech and language problems. You'd also see delayed motor development and a general lack of coordination prior to the development of early onset schizophrenia, but I'm not quite sure in adult onset, but it wouldn't surprise me if that were the case. I just don't know for certain. And also in the cognition, the cognitive task that I was discussing earlier, where participants had to find an object behind a screen and then do a distractor task and then relocate the object. I believe that they also found the cognitive deficits to be the case even in relatives or in people that were schizotypal. So I hope that answers your question. Okay, what does secondary to a chromosomal abnormality or secondary to a single gene disorder mean? So this is biology part of the ASD lecture. So the general consensus has been that there's some genetic component to ASD. So twin studies conducted so far suggest heritability in the range of 60 to 90%. Although at the same time, only about 10% of children with ASD do have a genetic disorder. So we think that autism is probably secondary to a chromosomal abnormality or secondary to a single gene disorder, meaning that these features are the results of something else they're a byproduct of. So an example of this would be the case of Rett's, which is a single gene disorder that, as you know, was previously under the autism spectrum disorders umbrella in the DSM-4, which presents very similarly to autism, and it is the result of a single gene. Okay, so in class, Professor Weinberg used the example that anhedonia is specific to depression. So if you have anhedonia, then you have depression. However, if I'm not mistaken, we also learned that anhedonia, or at least something that looks like anhedonia, is present in schizophrenia. So how can we say that anhedonia isn't? So I think the idea here is that anhedonia isn't a hallmark symptom of schizophrenia like delusions, hallucinations, or disorganized speech are. It's kind of encompassed within the A5 criterion, which is negative symptoms. But Dr. Weinberg also mentioned in class that there is quite a bit of overlap between schizophrenia and depression in terms of the negative symptoms that you see. But I'll definitely look into that more just to make sure. And I'll either make a post or let Aislinn know if I find anything to the contrary. Okay. disorganized speech and thought in schizophrenia, does this count as a positive or negative symptom? So I believe that disorganized speech and thought would count as a positive symptom. But just keep in mind that people with schizophrenia may also exhibit alogia, which is a poverty of speech, and that would be considered a negative symptom. Okay. What is a nihilistic delusion? So a nihilistic delusion is the belief that you or the world doesn't actually exist. So someone with nihilistic delusion believe that everything around them, including their own existence, is just an illusion. Okay, what is meant by disorder of relating, which is one of the 6 categories within the schizophrenia diagnosis that we went through? So disorders of relating refers to how patients with schizophrenia are interacting with the world around them. So typically people with schizophrenia may be drawn or be preoccupied with their own internal world. They also might have disordered volition, which means that they aren't really doing anything purposefully. And Dr. Weinberg mentioned in class that this is very similar to a motivational syndrome, which I believe is covered in your textbook. And it also relates very strongly to anhedonia. So it's disorder of relating. Just think that it refers to how people with schizophrenia are kind of interacting with the world and going about their life in the world. Okay. In the text, it says there's no difference between sexes, only at a younger age for schizophrenia. But in lecture, she says that the ratio is 1.4 men per 1 woman. So is there a sex difference between men and women for schizophrenia? There is a slight sex difference. So 1.4 men per every 1 woman isn't really much of a difference at all, but it definitely is a difference. So I would assume that the number that was given in class, which is the 1.4 to 1, takes into account those sex differences in childhood, whereas the textbook says there's no difference except in childhood. So if that makes sense. I believe that they're both saying this differently. Okay, so I have one last question that was posted on the my courses board before this review, and then I'll go over into the chat. And I'm happy to go back and clarify anything or answer any new questions. So how are female sex hormones protective for schizophrenia? So okay, so I can't really tell you why exactly that appears to happen. So I'm not sure in general knows exactly why that happens, but I'll walk through the graph, which is this right here, that we went over in class, just to kind of show why we think that is. So you can see here that the onset of schizophrenia for males decreases over time, whereas there's a little spike here for females. And this spike coincides with menopause, which is when ovary function stops in women. And what that means is that there's a decrease in estrogen in a woman's body at that time. And additionally, late onset schizophrenia is markedly more common in women compared to men. So that's why female sex hormones are believed to have a protective effect, because of this spike that we're seeing here, which is during/after menopause happens. Okay, so could we go over the difference between a disease marker and a sensitivity marker again? Sure. So A disease marker is just something that occurs in nearly all people with the diagnosis. And sensitivity is more of a characteristic of a good marker. So if a marker is sensitive, that means that most people with the disorder will have it. And so you want your marker to be something that's seen in most people with the disorder, meaning that you want your marker to be sensitive. Sensitivity is more of a characteristic of of a marker. Okay, so that's all the I have for now. So I'll hang out here until 7. I'll go and quickly check and see if there are any more on the discussion board, or if you have any questions that you want to leave in the chat. I'll be here for another 20 minutes. Okay, so it looks like there weren't any other questions. So I'm going to end the stream now. But remember that Aislinn will be holding another review session tomorrow night. And you can always email our TA account if you have any more questions. So good luck on the exam, and I'll see you all on Wednesday.